aneurysm when he was 21. So I phoned 6 different opticians and asked them for it to be seen, and I was told no, there was no appointments. And they said, has he got a headache? I said, no. They said, well, we can't see him. No, that was a receptionist triaging a patient on a phone. He didn't want to go near a hospital. He didn't want to go and bring anything back to me, and he collapsed at work. And he died on the 3rd of September with a brain aneurysm. The hospital consultant, the neurologist, told me, Caroline, Craig didn't die of COVID. He died as a result of COVID because he couldn't get seen. So because he didn't have a headache, they played lottery with his life and he died. They were just so unprepared.
We didn't have any PPE at all at that point. We slowly started getting simple kind of, just the masks that everyone wears out here, nothing that was proper.
They didn't give access to the FFP3 masks to the pharmacy sector, it was just the kind of paper masks. How effective are they?
So we were going in to see patients in the paper masks and starting life support on these patients, but we were unable to insert airways and manage their oxygenation until someone in full respiratory protection arrived. Now that process took up to 3 or 4 minutes to get fully dressed and fully in that respiratory protection, and by the time that we arrived and then someone had arrived to then put the respiratory protection on, they were often beyond help before we'd even started. We'd done back-to-back cardiac arrests of patients under 60, and it was a man he would have been 34, and I'd been to see him 2 days before, and he wasn't sick enough to take to hospital the day that I'd seen him. He was sick enough to go to hospital, but for the hospital at the time, he was not sick enough at that point. There was no space for people that were in that horrible middle ground of poorly but not poorly. I can't drive past that house without seeing it. And I'm not alone in that story. The amount of people that we went to 2-3 days before that were poorly, and in any other day, any other week, would have probably been rushed to hospital, put in the resuscitation room and aggressively managed and taken to intensive care. The only way that you can go home at night is knowing that you're not going to save everybody, but knowing that there are people out there that we probably could have. Had the system been more ready, had the money been spent maybe more effectively, had they not been running at 105% capacity before this happened, then maybe this person would have been alive. Maybe this person would be able to tell his story.
We also decided we had to do lots more home visits. Most people, it was better for us to go to them than them to come to us. So we're sort of standing on balconies trying to put on, don and doff our PPE, and before we went into a house which was COVID infected. I can remember going and seeing one of my patients who had rung me in the morning to say he was sick. And I said to him, I think you need to go to hospital now. He said, I'm not going to hospital. I went to see him on my way home into the room where he'd been all day dying. I did get him into hospital that night, but he was dead by the morning.
I was taken straight away into intensive care, and they thought I was going to die at that point. I remember lying in bed and the doctor standing by the side of my bed saying, will you sign a piece of paper to let us put you to sleep? So I said, yes, will I wake up? And the doctor said, well, we've got a 50-50 chance. And then I said, if I don't sign, he said, well, 0. I am a different person, and my body is different from before. You see, I have permanent damage from COVID, so it's like another kind of long COVID. So my eye that I can't really see with, my ear that I can't really hear with, my numb toes. I mean, people in my situation who maybe are in their 20s, 30s or 40s, perhaps this is more bewildering than for me. This may well have a huge knock-on effect health-wise. We just don't know at the moment. A big change has happened, and it can't just be solved by saying there is this virus and this is what happened to people's bodies, the end. It can't be solved that way.
Obviously at the time you're very anxious, very scared. When you've got your nearest and dearest near you, you're very worried about that and passing things on. And again, the responsibility you've got towards your colleagues.
If you don't know if the PPE is appropriate for the threat that we're facing, tell us, and then we can mitigate it. I was out with a colleague, and I had a patient was coughing, and there were visible droplets coming off of her, and she coughed down onto my face. I remember it reaching the top of my nose, and I tested positive 2 days later. That was the first time I got it. And at the time, my wife was 6 months pregnant, and I didn't know if I was going to kill her. I didn't know if I was going to kill my unborn baby. We tried so hard to play the game. We tried so hard to make sure that people were safe.
There was a call out for people to help triage on 111, which was basically calling back people who thought they had COVID. We were making decisions about whether they were ill enough to go to hospital, essentially, because we were trying to stop everyone going to hospital. There was no way hospitals were going to cope if everyone who had COVID went to hospital. It was very difficult. It was horrible, because I knew I might be making wrong decisions. You know, I knew I might be leaving someone at home and telling them they shouldn't go to hospital when they should.
You know, I think it's also kind of really exposed some of the big structural inequalities that exist in society. You know, like whether it's poverty and in terms of ethnicity, and probably also, I think now just really laid bare how fragile the NHS is.
It just kind of highlights like the institutional and systemic like racism that's like built into, you know, places like the NHS, because it was all black and brown people that were the most affected and the first affected as well. That's another thing that kind of like affects training and everything else, because already you know that people are looking down on you in a certain way, and you can tell. I mean, like sometimes it's explicit, sometimes it's implicit, and there's always a baseline level that you just have to unfortunately accept. You know, you just have to accept it.
In my intensive care ward, nurses were going from bed to bed, which is absolutely forbidden. You have one nurse per patient 24 hours a day. There weren't enough nurses. When I look in my patient diary, it says physiotherapist, I came in to help. Speech and language therapist, I came in to help. And they weren't trained to be ICU nurses who are ready for bereavements, ready for people dying, boom, just like that in front of you. And so they were traumatized. And there are people still recovering from this. I've spoken to nurses who've not been able to go back.
When I reflect on it now, what I really believe is that had the NHS been in a better place than where it was when this hit, we would have managed it better.
Just think about the healthcare workforce that you are developing. You've like stopped teaching. You don't have as much of that sort of, you know, learning from the seniors. Everyone's a lot more isolated. Just the standards have dropped ridiculously.
We see it now. You know, I'm 4 years post-registration, and I'm burnt out. My colleagues are burnt out. The moral injury that my profession, my colleagues have sustained is not to be understated. The compassion fatigue. More colleagues than I'd care to mention have gone part-time, have found other jobs. Some have left the profession entirely. Some have left healthcare entirely because of that 2-year period was too much.
Thank you very much. Could we alert the people watching who've left the hearing room, please, to come back? Sorry, I think I said 20 minutes. So I gave the wrong time estimate. Apologies to everybody. I'm sorry, I gave the wrong time estimate, so for those who are returning. Thank you. Ms. Carey, King's Counsel.
Thank you, my lady. On the 23rd of March of 2020, when the then Prime Minister Boris Johnson told the country to lock down, the broadcast included the following phrase: stay at home, protect the NHS, save lives. And the focus of the inquiry's Module 3 hearings will be on some of those words and the ultimate questions: did we protect the NHS? Did we save lives? And perhaps as importantly, why did we need to protect the NHS, and at what cost? What cost, for example, to those people who did not have COVID, but rely on healthcare systems to treat non-COVID conditions? What cost to the physical and mental toll on healthcare workers? What cost to those who could not visit loved ones, who had to shield, to those now living with long COVID? And what cost, my lady, to the families of all those patients and healthcare workers who died? As my lady knows, between March 2020 and February of 2022, death certificates show that there were 186,668 deaths involving COVID registered in the UK. The death certificates record the place of death across all 4 nations, and it is in fact between 60 and 70% of people who died from COVID did so in a hospital. The first healthcare workers who died were on the 25th of March of 2020. And the impact of dealing with so many deaths is just one of the many topics covered by Module 3's Every Story Matters healthcare record. That report analyses and brings together over 32,000 stories related to UK healthcare systems and includes contributions gathered from 450 interviews conducted across the UK with people impacted by the pandemic, along with hearing from those who engaged with the discussion groups. That report includes quotations which powerfully depict the daily realities of life and death within the healthcare systems. And let me just quote 2 at the outset. A hospital porter said this: the fact that people were in ITU and they were alone was horrible, because you could just see it in their eyes. You could see it in the eyes of the staff, the nurses, the doctors. At the height, it was really a horrible place to be. That was probably the thing that will stick with me the most, is that so many people died on their own, or so many people died with only one family member around them, which was horrific. A hospital cleaner said this to Every Story Matters: I was cleaning her room, and I remember she took off her mask to me. She was like only 24, 25. I'll never forget her. And she says, I thought COVID-19 wasn't a real thing. She went, but honestly, it's killing me. That cleaner broke down when he spoke to Every Story Matters and said this: it makes me quite emotional. Actually, it was sad. It is not possible or practical for me to reflect in this address the many thousands of stories that people have shared with Every Story Matters. But the report itself will be published today at noon on the inquiry's website, and it is hoped that it is a lasting account of the very real human impact that the pandemic had. There will be similar reports for other modules, and I know my lady would wish to encourage as many people as possible to participate in this vital part of the inquiry's work. And so to Module 3. This opening is an introduction to just some of the topics and issues that you will be asked to consider in Module 3. And can I ask, please, that the scope of Module 3, ending 474319, is put up on screen. Time doesn't allow me to go through each and every one of the particular aspects of Module 3 that will be examined. It is necessarily broad. It is undoubtedly ambitious. Covering, as it does, the impact on primary, secondary and tertiary care in all 4 nations of the UK. The time frame for the examination of this module's purposes is the 1st of March 2020 to the 28th of June 2022. We've called it the relevant period, and you may hear me refer to it as such throughout. Primary care, as you know, includes but is not limited to general medical practice and community pharmacy. Secondary care includes planned or elective care that usually takes place in hospital, the emergency and urgent care. It includes 999, ambulance services, emergency departments, acute hospital admissions, and some mental health services. And tertiary care, my lady, includes highly specialist care provided to patients who've been referred from primary or secondary care. In the context of this module, this may include treatment for more complex cases of colorectal cancer, inpatient children's mental health, and specialist intensive care. And you can see set out there, and it's on the Inquiry's website, the 12 different areas that the module will examine over the next 10 weeks. Whilst formal in its drafting, at its heart, you may think at a more fundamental and human level, the sorts of questions that may need to be considered in Module 3 include these. Why couldn't I see my GP? How was I protected from getting COVID-19? Where was my ambulance? Why was my treatment delayed? Did I receive the type of care I needed? Did my loved one? Why couldn't I visit my loved one in hospital? Were healthcare staff protected, looked after? Or perhaps more simply, was I safe at work? What was done to help with the long-term consequences of COVID? These will all be aspects of the evidence heard in Module 3, which may overlap with and indeed complement work being done by other modules, in particular Module 6, examination of the pandemic on the adult social care sector. To take an obvious but hugely important example, issues relating to the discharge decisions of hospital patients into care homes without testing, well, they are matters important to both modules. And Module 3 will look at the impact of the decision as it affected hospital capacity. Module 6 will look at the impact of the decision on the care sector. In order to examine these matters, Module 3 has requested over 250 witness statements, obtained 10 separate expert reports, commissioned independent research project looking at decisions made by health workers about escalation decisions. I'll return to that in a moment. The inquiry's also gathered evidence from a number of spotlight hospitals across the UK to help examine what was going on the ground. And taken as a whole, the spotlight statements provide evidence about matters such as the impact of significant staff shortages on staff-to-patient ratios, the physical and emotional toll on staff, the significant efforts made by those hospitals to increase their capacity for intensive care unit beds at pace, and the serious and wide-ranging issues with the suitability and reliability of PPE that was supplied. And my lady may hear of some innovative ways that staff and management filled those gaps. In total, over 16,500 documents have been disclosed. It amounts to over 225,000 pages of evidence. And that work has resulted in a huge body of evidence. Many of the statements run to hundreds of pages from which you'll be able to draw your conclusions and, importantly, make recommendations to help the healthcare system's response in the future. I know that will be assisted by the 36 core participants and their questions and submissions. The reasonableness or otherwise of actions and of decisions taken by those responsible for the healthcare systems will be an important consideration for your ladyship. And I know that you will not be judging decisions made with the benefit of hindsight. Hindsight's invariably 2020, and so would not be an accurate or fair way to consider unprecedented decisions that had to be made quickly in highly pressurised environments. Many of the witnesses will tell you that there were no good decisions. Rather, it was a case of what is the least bad decision. At the outset, it should be noted that when the government departments were asked to provide statements, they were asked to identify which individual would be best placed to provide the statement and who was able to speak knowledgeably about the matters set out. Accordingly, the inquiry is able to draw upon a wide range of witnesses, some of whom were in post throughout the relevant period, some of whom may have been in post for only part of the relevant period, and some who've now taken up the role, heading up the organisation, and so can bring a slightly different perspective as to where we are now in 2024. Irrespective of which camp the witness falls into, witnesses have been asked to reflect on what worked well as what did not. And for those giving evidence, may I make this plea? Please be prepared to assist in real practical terms when asked about recommendations that your ladyship may wish to consider. Whilst it's clearly important that in Module 3 the inquiry considers what decisions were taken and why, so that lessons can be learned, Module 3 has an important forward-looking perspective, as will be reflected in many of the questions during this public hearing. At the outset, it may assist if I briefly outline the structure of the healthcare systems in each nation and the key individuals from who you will be hearing. As health is a devolved matter, there are 4 distinct health systems within the UK. And whilst it may be an oversimplification and the names and terminology may vary between the nations, it may be helpful to think of the structure in each nation in this way. The government minister sets the strategy, the respective government department devises the policy to deliver that strategy, and then each nation has its own bodies, organisations to put that policy into practice. This map, and I'm going to ask please that INQ 474319 page 3, thank you, is put on screen, may help give an overview of the landscape of the healthcare systems during the pandemic. Now, some of the names have changed, and indeed some of the numbers, in particular the clinical commissioning group numbers, have changed. You will see that in England there are 135, or there were, I should say, 135 clinical commissioning groups, representing the figure in 2022 to 2021. There were 7 local health boards. There are 5 health and social care trusts. There is, in fact, a 6th trust, the Northern Irish Ambulance Trust, but we haven't depicted that on the map. And there are 14 geographical health boards in Scotland. So turning briefly to England. In England, the Department of Health and Social Care, DHSC, supports and advises ministers and the Secretary of State of Health and Social Care. Now, the pre-COVID understanding of roles and responsibilities regarding pandemics in DHSC and a number of bodies is undoubtedly a matter you're going to be hearing about, and it might be more easily understood by reference to the diagram on page 4, please. And if we could just enlarge it. These are terms with which my lady will be familiar and will become more familiar throughout. One can see DHSC sits at the top. There was the Pandemic Influenza Preparedness Board and Programme. And then under that, Public Health England, NHS England and NHS Improvement, then down to the CCGs, the NHS providers, and a number of expert advisory committees. And I know you'll be familiar with the work, for example, of Nerve Tag and the other committees set out there. DHSC is headed by its permanent secretary, Sir Christopher Wormold, who I know has given evidence in earlier modules. And the permanent secretary supports the government minister, who's the head of the department, who is in turn accountable to the Prime Minister and others in Parliament for the department's performance. During the pandemic, the Secretaries of State were Matt Hancock until his resignation in June 2021, when he was succeeded by Sir Sajid Javid. And the Secretary of State has a statutory duty to take such steps as he considers appropriate for the purpose of protecting the public in England from disease or other dangers to health. And he has a power to take such steps as he considers appropriate for improving the health of people of England. The principal way he does that is through Public Health England, with both the Department and Public Health England having responsibilities for planning for and indeed managing the response to emergencies and health protection incidents. On the 1st of October in 2021, Public Health England was replaced by the UK Health Security Agency, UKSA as it's sometimes referred to, as a part of wider government restructuring. And you will be hearing from UK HSA's CEO, Professor Dame Jenny Harries, and its Chief Medical Advisor, Professor Susan Hopkins. One can see on the screen there reference to NHS England. NHSE, as it's often shortened to, commissions healthcare services and has responsibility for arranging the provision of services for the purposes of health service in England. For the majority of the pandemic, NHSE worked together with NHS Improvement. And so many of the documents we will look at will make reference to both NHSE and NHSI. The chief executive officers of NHSE were Sir Simon Stevens until July 2021, and then Amanda Pritchard, who was in fact the chief executive of NHSI. And its board members include Professor Stephen Powis, who is the National Medical Director. You'll be hearing from the latter two witnesses, both of whom have provided lengthy and comprehensive witness statements. And my lady may recall that the map referred to 135 CCGs. They are responsible for planning and commissioning health services in local areas using the funds allocated to them by NHS England. There are then a number of services provided by the NHS trusts, and a trust indeed can run multiple hospitals and community sites. It is NHS England who is responsible for setting an emergency preparedness, resilience, response strategy, or EPRR, for the NHS. For the purposes of this relevant period, NHS England's EPRR framework from 2015 applied. And that framework describes in terms the level of response and coordination required, which may change as the incident evolves. And so can we call on screen, please, page 5. This is the EPRR framework in place in England, various different levels set out there. And the incident level informs how the EPR framework will respond. Throughout the relevant period, the NHS in England was either at a level 3 or level 4. And in fact, the NHS in England spent 421 days at level 4 between the 30th of January 2020 and the 28th of June 2022. And you can see there that level 4 essentially means that NHS England National Command and Control will support the NHS response, and it's NHSE's job to coordinate the NHS response in collaboration with local commissioners. Now this, my lady, is a framework specific to England. You will hear that each nation had a different approach to EPRR frameworks and or had different frameworks. And so the English framework is very much just to give you an example of how an EPRR framework might work. You will hear how the Department of Health and Social Care developed a COVID-19 action plan in early March 2020 to provide the public with information about what the government knew, had planned for and was planning for. And the department devised an internal battle plan, to use their phrase. Can we look at page 6, please? There's the COVID-19 battle plan from March 2020. It split the work into various work streams which are set out underneath the contain, delay, research, mitigate phases. And my lady will see there that work stream 1 was to sustain the health and social care resilience, especially critical care capacity and workforce. It was to ensure supplies to the NHS, including PPE and ventilators. There was a work stream delivering widespread testing and work streams in relation to accelerating technology, social distancing and shielding. My lady, the effectiveness or otherwise of this plan will doubtless be something that you will wish to consider as the evidence progresses. Now I turn to the structure in Northern Ireland. Since 1973, there's been an integrated health and social care system in Northern Ireland. The Northern Ireland Executive is composed of 9 departments, each with a ministerial lead. The Department of Health is one of those 9 and is responsible for health and social care legislation and policy. Until April 2022, there was a single health and social care board that worked in conjunction with the Public Health Agency in Northern Ireland, which commissioned services to meet, need and promote general health and well-being. And the health and social care services that are provided by 5 health and social care trusts. Can we have a look, please, at page 7? There are the 5 trusts, one in Belfast, and then North, South, Eastern, Southern and Western. And as I said, the 6th trust provides ambulance services for the region. And my lady, the health and social care structure is different in Northern Ireland, given that in England, Scotland and Wales, provision of social services remains the responsibility of local authorities. Robin Swan was the minister at the time Module 3 is examining. And in terms of the structure, there is what is known as the top management group and the departmental board, who have responsibility for overall corporate governance of the Department of Health. They also ensure that the minister's policies and priorities are implemented. In Northern Ireland, the Emergency Response Plan 2019 was the plan that was used in response to the emergence of COVID-19. Now, that response operated under a gold, silver and bronze model, with the Department of Health operating as a gold command, setting the broader and longer-term responses to the pandemic via a strategic cell and the Emergency Operations Centre. And it was the Emergency Operations Centre that was responsible for managing the flow of information into and out of the strategic cell and between the Department of Health and Social Care sector and indeed across the wider Northern Ireland executive departments and the UK government. Under that was the Silver Command, where the bodies such as Public Health Agency in Northern Ireland, known as PHA, whose responsibilities include health protection. And during the pandemic, this entailed Public Health Agency providing SITREP data, situation reports, to the department. They maintained changed surveillance systems of COVID-19 cases, and they looked at outbreaks, and they adapted guidance on the management of cases, to name just a few of their responsibilities. And at bronze level, which is essentially the operational level, were the Health and Social Care Trusts themselves. So although I've referred to gold, silver and bronze structure by reference to the position in Northern Ireland, there is a similar command structure operated in a number of places, including, for example, in the Welsh health boards. The Department of Health in Northern Ireland was responsible for the development and management of the COVID-19 dashboard, which included data from the trusts and analysed trends in pandemic-related data, including, for example, attendances at emergency departments, number of people being admitted to hospital, number of cancellations of elective admissions and others. The then Health and Social Care Board also coordinated a range of groups to support regional communication across Northern Ireland, including among frontline staff such as the Critical Care Network for Northern Ireland, which also developed a daily situation report informing the system of bed availability and demand by unit. And my lady, of course, in relation to Northern Ireland, although the Republic of Ireland and Northern Ireland are separate jurisdictions, from early on in the pandemic, there was collaboration with the Republic on public health policy, including arrangements for the sharing of information on infectious diseases. To Scotland. The government in Scotland is structured into a number of directorates, of which the Health and Social Care Directorate is one. The directorates and their related public health bodies are responsible for putting government policy into practice. The Scottish ministers, health boards and local authorities are all under a legal duty to continue to make provision to protect public health in Scotland. And indeed, the Cabinet Secretary for Health is under a similar statutory duty to promote a comprehensive and integrated health service. Those Cabinet Secretaries during the relevant period were Jean Freeman until May 2021, and thereafter Hamza Yousaf, both of whom will be giving evidence. Very early on in the pandemic, on the 17th of March of 2020, Ms Freeman advised the Scottish Parliament that the NHS would be placed on an emergency footing for at least 3 months. And she set out that she was giving instruction to the NHS and the individual health boards to do all that was necessary to manage the expected increase in the number of cases of COVID-19. In short, my lady, this meant the strategic direction was taken, was determined by Ms Freeman, and all of the Scottish NHS boards would follow the same set of actions, albeit the operationalisation of them may differ according to local circumstances such as geography. You will hear from the Director General of the Directorate, Caroline Lamb, who's been in post since January 2021. And the Director General has a number of roles, including having oversight of all of the health boards in Scotland. And during the pandemic, new directorates were established, such as the Directorate for COVID Health Response, the Directorate for COVID Public Health, and there was a Directorate for PPE. The Health and Social Care Directorate in Scotland provides a policy and a delivery function, as well as oversight of the NHS. The Health and Social Care Management Board is the main decision-making body of the Directorate, and its remit is to be collectively responsible for strategy and performance. Now, during the first 3 months of the pandemic, between March and May 2020, that board was briefly reconstituted to become known as the Planning and Insurance Group, which was collectively and individually accountable for the strategy, before reverting in due course back to the board. My lady may recall from Module 2A that the Scottish Government's approach to decision-making during the pandemic was set out in its framework document published in April 2020. That included suppression of the virus to the lowest level possible while seeking to minimise the broader harms. And that framework identified in broad terms 4 main ways COVID caused harm: direct and indirect health harms, and indeed social and economic harms. And whilst that framework was not a hierarchy, you will hear that preventing direct harm, namely the mortality and morbidity associated with COVID, was the Scottish Government's paramount concern. There are 14 geographical health boards and 7 non-geographical special boards that are all supported by NHS National Services Scotland, or NSS, and indeed by the Healthcare Improvements Scotland. And can I just put up on screen page 8, please? There you can see the geographical boards set out, and you'll notice immediately, my lady, the very wide spread of regions that they cover, territory that is covered, indeed numbers of people within each of those regions, and special NHS boards are set out there. And the boards are delegated responsibilities by the Cabinet Secretary to plan, commission and deliver healthcare services and take overall responsibility for health and well-being. NSS provides strategic support. For example, during the pandemic, they provided services related to national screening programmes, many of which in fact were paused during the pandemic, in common with the position across the UK. And NSS was also responsible for procuring and delivering PPE. NSS had a public health and intelligence unit, but on the 1st of April of 2020, Public Health Scotland was established, and most of the unit's functions were transferred to Public Health Scotland. There is one important exception to that, and that was the service provided by the Antimicrobial Resistance and Healthcare Associated Infection Service, or ARHI for short. ARHI provides national expertise for infection prevention and control. ARHI's IPC guidance was published in what is called the National Infection Prevention and Control Manual, NIPCM. And that manual was first published in Scotland in 2012, and it's important because it now forms what I may call the backbone of much of the IPC guidance used across the UK today. ARHI played an important role in the UK-wide COVID-19 IPC guidance. And in particular, one of ARHI's former members, Lisa Ritchie, became the head of infection prevention control at NHS England, as she initially chaired the UK IPC cell, and it was the UK IPC cell that made the infection prevention and control recommendations that underpinned the UK IPC COVID-19 guidance. And may I just say one thing about that cell? That cell brought together IPC leads of the NHS and the public health bodies from all 4 nations. Each national representative on the cell was responsible for taking the cell's recommendation back to its respective country for approval, usually either by the Chief Nursing Officer or the Chief Medical Officer. It was not technically a decision-making body. However, you will want to consider the extent to which, if at all, the UK IPC cell's recommendations were altered and or overturned, as there may be little evidence of that. Thus, you may come to the conclusion that it's likely that the cell was, de facto, the body making the decisions in respect of the IPC guidance. The structure in Wales has the Welsh ministers who set the high-level policy framework and the targets for the health service, which are then delivered by the local health boards and NHS trusts in Wales. There is a Health and Social Services Group, HSSG, which sets out the minister's expectations in respect of planning and performance and the assurance it seeks from NHS organisations through its planning, delivery and compliance frameworks. The NHS in Wales is principally made up of different types of statutory bodies, the 7 local health boards, there are 3 trusts and 2 special health authorities. Now in Wales, the healthcare services are primarily delivered by the 7 local health boards, who are responsible for planning, securing and delivering healthcare services for the benefit of their resident population within their geographical area. The term NHS Wales is commonly used to refer collectively to the local health boards and indeed the special health authorities, but unlike in NHS England, there is no central legal entity of this name. The ministers in post during the relevant period were Vaughan Gething until May 2021, followed by Eluned Morgan thereafter. And while delivery of the healthcare services is the responsibility of the NHS bodies, the Welsh ministers are responsible for monitoring the financial duties of the NHS bodies, and each board has to submit plans to the minister, setting out how they will use the funds, and those plans are then approved by the Welsh minister. At the start of the pandemic, Dr. Andrew Goodall was the Director General of Health and Social Services, also the Chief Executive of NHS Wales until September 2021, when he became the government's permanent secretary. Judith Paget took the role of Director General thereafter, and that of Chief Executive of NHS Wales. In Wales, in addition to the UK pandemic flu strategy to 2011, Wales also followed a number of other plans. There are 3 in particular: the Pan Wales Operational Response Plan from 2019, the Wales Health and Social Care Influenza Pandemic Preparedness Response Guidance issued in February 2014, and then there was the Pandemic Influenza Extreme Surge Guidance for the NHS in Wales. Now that latter guidance had been in draft form at the start of the pandemic, was updated for COVID-19 by the COVID-19 Health and Social Services Planning and Response Group. And that planning and response group's role was to consider the reasonable worst case scenarios for COVID risk assessment and coordinate the response to planning across Wales. Public Health Wales was part of that planning and response group, and you'll be hearing from Public Health Wales' National Director. And so that, my lady, was a very quick and summary attempt to set out some of the structures in place at the highest level of planning and preparedness across the 4 nations. At a more local level, the spotlight evidence attests to some of the plans put in place by the trusts and hospitals and the considerable efforts they went to as the pandemic struck. May I deal, my lady, with one other topic, perhaps before we turn to our mid-morning break? And it's at the outset the issue of inequalities. Laws across the UK require public authorities to have due regard to certain equality considerations when exercising their functions. And I refer to these legal duties because, as my lady knows, the inquiry's terms of reference specifically set out that the inquiry will consider any disparities evidenced in the impact of the pandemic on different categories of people, including but not limited to those relating to protected characteristics under the Equality Act 2010 and the equality categories under the Northern Ireland Act 1998. I know that in previous modules you have heard from a number of experts who provided your ladyship with evidence about some of the many inequalities that existed pre-pandemic, which were exacerbated by the pandemic. You will recall the evidence given by Professors Marmot and Bamborough, who in Module 1 spoke, for example, of the socio-economic inequalities, such that the more deprived local authorities in the UK have worse health than the less deprived, and that those in more deprived areas have shorter lives and live more years in ill health compared to people living in less deprived areas. The expert spoke of ethnic inequalities in health, where notwithstanding the concerns about the reliability of data, there was some evidence that ethnic minority people may have much poorer health than white people. Those ethnic inequalities have particular significance in my submission for the NHS. Amongst all the staff employed by the NHS, and there are 1.3 million in England as of March 2020, approximately 21% are from a black, Asian and ethnic minority background, or to put another way, 270,000 people. That includes a quarter of nurses and over 40% of doctors. And my lady will hear about the evidence of the disproportionate number of black, Asian and minority ethnic healthcare workers. You will hear concerns that those group of healthcare workers were often deployed to the frontline roles. So they were there with direct contact with COVID-19 patients and so needed PPE that not only fit them, but took account of religious dress, facial characteristics such as hijabs or beards. You will hear, my lady, that risk assessments for black, Asian, minority ethnic workers happened too late or not at all. You will hear that some staff in non-clinical roles, the porters and the cleaners, were not provided with PPE at all. And there is concern about the lack of engagement with groups set up to represent black, Asian and minority ethnic healthcare workers. The communications with that group were not tailored or sufficiently tailored to those communities. Many witnesses will attest to the efforts they made to bring these matters to the attention of the respective governments and key decision makers, for example, the ministers, the chief medical officers, the heads of the departments, and indeed what steps were taken in response. You will hear about some specific examples of potential racial inequalities. May I just give two examples? During the pandemic, there were concerns about the use of pulse oximetry for COVID-19 patients being managed at home. Now, pulse oximeters can identify a drop in someone's blood oxygen level, which can be an indication, amongst others, that the person's condition is deteriorating. From November 2020, pulse oximeters were used in England to monitor patients who were well enough to stay at home, but who were most at risk of becoming seriously unwell. And concerns emerged that suggested that inaccurate and variable readings when the device was used on a darker skin were not appropriate. So, put it another way, the reading was inaccurate because it would suggest that oxygen levels were okay, when in fact they weren't, and it resulted in delays in those people potentially being taken to hospital and being treated. The NHS Race and Health Observatory conducted a rapid review of the evidence of inaccuracies in pulse oximeters, and you'll hear more about that and the observatory's other work when Mr. Naqvi, their CEO, gives evidence. During an Every Story Matters listening event, healthcare professionals from ethnic minority backgrounds recalled their own heightened concerns about personal safety and the risk of COVID-19 after learning that people from those backgrounds were more at risk. You will hear, my lady, particularly at the start of the pandemic, that formal equality impact assessments were not always carried out. A consequence of this was that health inequalities, defined as avoidable, unfair, and systematic differences in health between different groups of people, were not properly taken into account when measures to address the pandemic were designed. And this gives rise to the risk that measures would fail to mitigate health inequalities, or worse, the risk they would exacerbate them. The pandemic brought other inequalities to the fore. In their witness statement, for example, Age UK highlighted that age is the single biggest risk factor for experiencing severe illness and dying from COVID-19. Age UK point to data which suggests that even after accounting for people's health, sex and ethnicity and other characteristics, when compared to someone aged 60, the risk of dying was about doubled for someone aged 70 and almost quadrupled for someone aged 80. PPE, masks and the like, made spoken communication more challenging, particularly for patients who have additional communication needs, such as the deaf and hearing impaired, who couldn't lip read when people were wearing masks. Some autistic people depended on facial expressions to aid communication, and clearly the masks impeded them. The increased use of remote consultations impacted many people. For example, the move to remote consultations was difficult for people who spoke no English or for whom English was a second language. For older people, for those who lack confidence in their ability to accurately self-test. In the context of maternity care, there is some evidence to suggest that early in the pandemic, remote support did not work well for those who were breastfeeding. And my lady, you'll hear from witnesses called on behalf of MENCAP and the Disability Charities Consortium. MENCAP CEO will tell you about MENCAP's concerns that visiting guidance had on those with learning disabilities and its concerns about do not attempt CPR. I'll return to that topic later. The Disabilities Charities Consortium raised similar concerns, and they rhetorically ask this. To use their words, they want to know whether disabled people were treated, quote, as an afterthought during the pandemic. My lady, these are just some of the disparities and inequalities that emerge from the evidence in Module 3. And I know my lady will be keen to hear more about these matters as the public hearing progresses. Might that be a convenient moment for a
Certainly,
break?
if that suits you, Ms Carey. I shall return at 20 to 12.
Thank you, my lady.
Rise.